Which article are we doing first? Which article do you guys want to do first? You want to talk about the D10, D50, and then we can also talk about the interesting case with intentional overdose.
Okay, sure. So do Ready? So, first case.
You're on.
All right, welcome to Journal Club. We are here at Monarch Boardroom today. It's August 1st. I know we had a bunch of viewers last week who made a lot of comments to us. So we are back one more time. This is our third Journal Club of the academic year, with a bunch of fellows all over the place and a bunch of us here today. We just came from tactical training exercise. And again, if you want to join our Journal Club list, there's about 13,000 of you now. Just send us an email through the fellowship webpage, which is always being updated, www.emsfellowship.com. And we have all these behind-the-scenes things going on for education and a variety of other things we're happy to share with you. And we usually post these Journal Club videos a few days afterwards. We posted a lot of articles for this week. We're not going to get to most of them, so we don't get to, we will actually move on to next week. And next week we will be, I think, where are we next week? Are we up in Newark next week?
Yes, sir.
Okay, so we're at Newark Beth on D11 for any of you next week. So I'm supposed to tell you to, if you like this on Facebook, then everybody will, if you like us on Facebook, everybody will be aware that we're transmitting, whatever the word is.
And share.
And share. share on Facebook, whatever that is. All right, so interesting cases. Who is interesting case?
You guys want me to do the interesting case first?
Yeah,
Okay.
yeah, you
Okay.
can talk about your concern.
Yeah. So I had a case.
Don't be nervous, though. There's only
There's
7,000 people.
Oh, okay. Okay.
So-
I had a case in the ER on my last shift, and it was actually a sign out that I got. So it was a patient who was a type 1 diabetic who had taken an overdose of about 6,000 units of insulin in a suicide attempt. And he came in and obviously was very hypoglycemic. Initially had a sugar, I think, in the 20s. Gave kind of the regular multiple amps of D50. Repeat checks still showed that his glucose was not going up. They gave him glucagon, still didn't work. And then they started discussing with our pharmacist and with our toxicologist some other treatments of possibly doing sub-Q octreotide, and then also potentially starting a D50 drip. They tried to do a D10 drip, and still the sugar wasn't coming up. So they ended up starting an actual D50 drip. And finally, after probably 6 hours, his sugar finally came up. And then I think they actually did end up giving octreotide as well. So finally his sugar started coming up into the 100s, 200s, and he was sent up to the ICU.
So this was an intentional overdose. So insulin's what? Insulin's also like a positive inotrope, right? Because we also give it for like calcium channel blocker overdoses, right? So he probably had a good squeeze, but with persistent hyperglycemia, 6,000 units is a lot of insulin.
Yeah.
What else could we have done for him besides D50 drip? Octreotide, I guess that was good, right? So that octreotide's somatostatin, right? So
Yeah.
I used to remember this. Like, I used to remember how to bolus it and drip it. I don't remember anymore. Is that a 30 mic bolus and a 30 mic per hour drip?
I think it is a 30 mic initial, but it's sub-Q, so I don't think there's a drip.
Oh, there's a drip.
There is. Okay.
No, we can drip it. It's much less. I don't think it's.
I just don't remember how to dose it. And what about, you can also do, for persistent hypoglycemia, I guess you can also do, I guess you could give steroids, but they have side effects. I guess you give growth hormone, that makes your blood sugar go up. That has side effects.
Ariana, was he altered? Was he able to like talk to you, or was he able to like eat, speak, anything like that, or was he just completely out of it?
He was, I believe he was out of it. By the time I saw him, his sugars were in the hundreds and he was up and screaming and being very rude. But
Okay.
he was definitely somnolent and kind of not, probably not able to take PO
Sure.
if you wanted to do it that way.
Right. So one of the podcasts that we were just talking about, they were saying that they had a patient very similarly, and they ended up or one of the things that they were considering was intubating, dropping in an NG tube, and then putting like complex carbohydrates like into the.
I think it was M&Ms, right? That they said they were
Yeah.
going to use in the
Yeah.
podcast because I heard this.
So that's pretty good. So they could do like a continuous like tube feeding, right? Almost through the
Yeah.
NG tube, right? That would make sense.
Right. Complex carbs are the best way to.
So like
I guess
Jeopardy
reduce,
or
yeah.
something along those lines continuously
Yeah.
for several hours, and
Mm-hmm.
yeah, that would probably make sense.
That would probably make sense.
Or J tube if you did push into the tube.
I wonder if we could just do a down off instead of having an intubate.
Yeah, you could do a down puff. What if you just did a down puff tube and just did continuous like tube feeds for several hours and be
Yeah.
done,
This is a possibility.
right?
Be way easier than trying to track down enough glucose.
To help the guy.
Right.
What kind of
Right.
insulin, I guess we should ask?
That was regular.
Is all regular
It
insulin?
was regular.
And so it's drips are in like micrograms, so you can do 50 to 100 micrograms per hour.
Yeah, that's it. I think it's 50-50 rule for octreotide, right? 50 mic bolus and then 50 micrograms an hour. Right, so octreotide or somatostatin is a 50-50 rule. And, all right, good. Anything pre-hospitally? Who was on primary?
We were kind of splitting it over the last couple weeks. I had a lot of pronouncements this week.
A lot of
A lot
pronouncements?
of pronouncements.
It's one of those
Right.
years, so.
I saw several people who unfortunately had been that way for quite a while.
Did you do anything interesting? Did you bronch anybody?
I did not bronch anyone.
All right.
I
Difficult airways?
No, actually, they were all pretty. The ones that I was present for, the medics did not need any assistance. So
No assistance? Anybody you did a
It was great.
transthoracic echo on?
I did not. Not
No
myself.
echo?
No.
All right. How about any of you guys anywhere else?
I have a good case.
All right.
So this is kind of an interesting case, I think. So I have a patient who came in. This patient was post heart transplant 2 months ago. The patient presented by EMS for chest pain. The call we got, they're coming in, lights and sirens, the patient's hypotensive, tachycardic, the EKG just shows a right bundle, and he's tachy at like 130s. And that's pretty much all the information they gave. They gave him some aspirin and they called it a day. When he came to us, so he was hypotensive, he was tachycardic, and he was definitely complaining of chest pain. So any thoughts off the bat?
Well, it's just post-heart transplant, so
Sure.
it could be rejection.
Okay, could be rejection. What else?
Post-surgery hemorrhagic shock, he's hypotensive and tachycardic.
Sure, hemorrhagic shock. I mean, the first thing I thought of
Tamponade.
immediately was, could this guy be in tamponade, right? So
Right.
he's a fresh heart. I mean, could this possibly be tamponade? It's hard to when they're a fresh heart because obviously, the pericardial sac has been pretty much, violated to a certain degree. But, to that extent, it can happen, and you can definitely have that kind of vessel rupture as well. But, the first thing I did was take a look at the heart. I did an EFAST really on him, so I took a look at the lungs, the heart, and look for the squeeze, look at the IVC to see kind of where he was.
So the good news is in 2018, you throw away your stethoscope because you have an ultrasound.
Right.
Right?
Right.
And you can tell infiltrate pleural effusions, pericardial effusions.
Right.
Everything, gallbladder, everything, and quicker than I can take my stethoscope off. So you only wear stethoscopes, look like a doctor.
I just do it to
Or
make it look
nurse.
fancy.
Or
Right.
nurse, or paramedic.
Or paramedic.
Right. So, I mean, didn't listen to him at all. I went straight with the ultrasound and quickly looked at the heart, looked at the vascular probe, looked at the lungs, Pavini B lines. He had a pleural effusion bilaterally, nothing, grand.
Small respect.
Small at best, and then he had no effusion, and his contractility was tachycardic, poor effusion, poor EF, so I wouldn't expect that for a transplant, but definitely there. And his blood pressure was probably like in the 80s or 90s. So we started initially giving him fluids, and I said, get some pressors ready just in case we need it. And while we're getting ready to kind of initially resuscitate this gentleman, he looks a little bit more altered. He looks a little bit more agonal, and like just as far as his pains, it's more anginal. He's like kind of getting a little bit more out of it, and then he seizes. And so in my mind, I already know where this is going. He's hyperperfusing his brain, and the next thing he went straight into basically a very agonal respiration. On the monitor, he went down to basically like the 70s and 60s, but I started CPR immediately. Just because his clinical presentation to me was, this guy's not perfusing his brain, this is why he's seizing, he's got agonal respirations, so we started CPR right away.
What was on the monitor?
So he was, I didn't even check for a pulse, but he was, the monitor showed basically a rate of 60 at best. And he had dropped from 130 dramatically into like the 60s. So we started CPR. We gave one round, gave epinephrine, and after 2 minutes, I got a heart rate, sinus tach at like 130, 140.
How much? So you thought he was basically like in like a PEA,
Right.
But you thought he was a narrow complex PEA,
Right.
And you thought really he was what we used to call pseudo EMD, which is an
Right.
electromechanical dissociation, which is pseudo, meaning in the old days we told people take your stethoscope, listen for an apical pulse. If you hear one, maybe they're just hypotensive. These are people in the ICU who have A lines in, their blood pressures are 50, and we treat them for hypertension. But in the ER acute setting, we don't have A lines in, so they're just hypotensive, and the answer to them is fluids and pressors.
Right.
So how much epinephrine did you give?
One round,
So, but like, did you give like 20 mics, or did you
1
give
milligram.
You gave 1 milligram.
straight up.
So you gave that really more, not because he was in cardiac arrest per se, but because he was hypotensive.
Right.
And you felt that he, I mean, this term in cardiac arrest is just a generic term.
Sure.
Right. I mean, to you, he was just hyperperfusing, so his
Right.
blood pressure was low for whatever reason, so you just wanted to bring it up transiently while treating him.
Right. So he got ROSC at 130, and that sustained for about 45 seconds. And we lost pulses after 45 seconds. And can I tell you what rhythm he went into? He went to a systole.
Even asystolic.
He went from a sinus tach rhythm at 130 and went straight into a systole.
Oh, man.
I had no idea what happened.
And at any of this point, did you look at the heart?
I did. And we confirmed, contractility at 130, and then all of a sudden he had no contractility whatsoever.
So he had no pericardial effusion,
No pericardial effusion.
and he had, and nothing was moving.
Nothing was moving. And that's when I looked at the monitor and he was asystolic. Because I was looking at the heart, he was tachy, and then he all of a sudden stopped beating. And he went straight into his systole. Never in my life have I seen that. And we started CPR again.
Was he on DIG and get calcium?
No. So I'm thinking, what could cause this to happen? So obviously, hyperkalemia is like syphilis of all EKGs, and I've seen hyperkalemia do crazy things. So I'm thinking, could this be hyperkalemia? So obviously, off the bat, I gave him calcium.
All right,
gave him.
So we know that when you have a PEA with a Y complex, it's more leans toward hyperkalemia.
Sure.
And we know that when we see bradycardia, we're big believers. Our paramedic calls us and just says, if there's nuance of bradycardia, we just throw calcium at him, right?
Right.
No questions asked, doesn't matter. If you're wrong, who cares? If you're right, you're going to save the guy's life, right?
Right.
Nuance of bradycardia. We find a lot of people don't even know this, but I don't understand why they don't know it. You just throw 1,000 calcium chloride, 10%,
Right.
So 100 milligrams per ml, throw 10 mLs at them, done. What if the guy is on DIG? What if he's on DIG? Because some of these people might be on DIG. I mean, this guy was a transplant, but we have a bunch of bad hearts who are on DIG. Does that matter?
No.
No, so it's just
Going hard.
another great myth in medicine.
Good
We wrote
myth
a-
in medicine.
We wrote a clinical pearl about this. This is made up. If you look at the data, it's just not true. And you can be digitoxic with hyperkalemia, give calcium, and be totally fine.
Right,
But it's a long perpetuated myth that most people still believe.
right.
All right, so you gave the calcium chloride, and it didn't do anything.
Sure. So,
I'm just guessing, is that right?
no. So while we're doing compressions, this guy's moaning and groaning.
Yeah.
And he's trying to pull his hands up while we're doing compressions.
Yeah.
And as soon as I stop doing compressions, he becomes unresponsive. So we were doing such good CPR that we were perfusing his brain very well.
Right. So I
And
just have
he
to
was awake.
I have to wonder two things. One, what's the guy's end-tidal CO2?
His end-tidal CO2 was 42.
He was already intubated at this point?
No, he was not intubated
Right,
because he was moaning and groaning.
So that's another question, when do you pull that trigger in this type of circumstance?
Right.
So we pulled the trigger about 10, 15 minutes into the resuscitation because he was still moaning and groaning. And he was breathing, he had good end-tidal.
Right. Listen, whatever you're doing to the left ventricle to have an end-tidal 42, you're doing something okay.
Right,
Especially if a guy had some asystole. Which,
Right.
of course, your first thought, I'm sure, is this can't be asystole.
He did it twice.
A lead became disconnected.
Nope, he did it twice. We got ROSC again, 130, went right into asystole. Again. Did it twice.
What?
Not once, but twice.
And you ultrasound the guy's heart,
I
and nothing
did.
was moving when this
Nothing.
happened. And then when he would
Nothing.
get Ross back, the guy had fair contractility.
Yeah, well, I would say marginal. I would probably, if I had to estimate it, he was so tachycardic, but I would marginalize it at 20 to 30.
So before he went down like this, did he get a 12 lead? Was there anything to
Right
indicate
bundle.
ischemia? That was it?
Yep. And lateral wall, probably ischemia, that's about it at best.
Old changes?
Yeah, unchanged.
I'm sorry?
Old changes or?
Or no?
I don't have it because he was a fresh heart, don't really have anything to
So
compare it to.
but when you looked at the LV, was there thinning of the wall? Or
No.
was it, there's no thinning of the wall?
No thinning of the wall. No. So I ended up giving him ketamine so I could give him a little sedation so I could intubate him.
Right, because you're certainly worried this is the first
And-
guy to become more hypotensive and go back into cardiac arrest.
Right.
Intubate him, ketamine is a pathomimetic, it's
Yep.
good.
It's not
But
going
then
to
we
hurt
always-
him.
Well, we always talk about this, like if you're in septic shock with one catecholamine in your body, ketamine will still make you hypotensive, right?
Right.
It's not it's a great drug, it's not a perfect drug.
And he's in cardiac arrest, I mean, at this point. But I have to sedate him in order to get the tube in at 10 minutes into the resuscitation.
Listen, there's been a study we reviewed 2 years ago, nobody believed it, said 15% of people in cardiac arrest have trismus and still need paralytics to intubate.
Right.
And all of our experiences were,
Agreed.
that's bullshit, it can't be true. It can't be 15% of people in cardiac arrest need paralytics, but in the biggest study ever done, that's what they showed.
Right.
So,
So we
all right, so you
use-
gave him ketamine, and
Right.
you were able to pass the tube.
So we use video laryngoscopy to visualize the chords.
Right.
While you
And
were doing
during
compressions?
But
compressions,
you didn't
Nice.
use the bronx.
no, didn't have the bronch at that time.
It was,
So during compressions, we're intubating him with video laryngoscopy, and with video laryngoscopy, I could see the cords moving.
pretty cool.
Amazing. This guy was breathing during compressions. It was great.
Yeah.
So we were doing such good, effective CPR. We intubated him successfully. And we had good end tidal. And we kept on doing our thing. We coded this gentleman for about 25 minutes, and I got sustained ROSC for
You could him continuously for 25 minutes?
I did. And we got ROSC after 25 minutes, and he was still tachycardic and hypotensive. I made the decision at that point to...
Was he still breathing over the vent and stuff?
No. No.
So
He wasn't breathing over the vent.
because obviously you're worried about non-stick brain injuries.
Right.
So he stopped taking breaths at all.
Right. So I couldn't tell whether or not he was sedated and wasn't breathing over the vent because he was sedated at this point now.
But you only gave him one dose of ketamine.
I did, but it was a good dose. So I wasn't 100% sure whether this gentleman was sedated now, so now I lost my neuro
It would
exam.
have worn off by now because now you're talking about 30,
Sure.
45 plus minutes.
Sure, I mean, it was like maybe 10 minutes later, because it was 25 minutes we got ROSC, and I tubed him about 10 minutes into the resuscitation,
Right.
10, 15 minutes into resuscitation. So I made the decision at that time to call our heart failure attending, one of our heart failure attendings, and I discussed the case with him. And I felt that this was at 2 in the morning, obviously. So I did two things. One, I called the coach STEMI on this patient. And the only reason why I did this was to mobilize the cath team, because I felt like this patient needed to go to the cath lab. Two, what I did was I called only heart failure attendings and made him aware of his patient, but also recommended that this patient be placed on ECMO. Due to the fact that we had good CPR, he had good, he was awake during compressions, and I think this person's salvageable with a fresh heart. He came in within, I would say, 15 to 20 minutes. Our patient arrested within 5 minutes of ROSC. And so we went back into the circle of doing cardiac arrest and doing CPR. So at this point, a decision was made to go forward with ECMO. The heart failure attending came in. We ended up putting this patient on ECMO in the ED, and the total time from his second arrest to ECMO being started and we taking our hands off the chest was 45 minutes.
Wow.
So this patient was down 25 minutes, then ROSC for 5, then down for 45 minutes, and then put on ECMO.
So obviously he got VA ECMO, and I'm sure that, what happened?
So during his entire second resuscitation and cardiac arrest, he was in asystole the entire time. After being put on ECMO, he was in asystole. He remained in asystole for 2 minutes. After 2 minutes, he started getting an ectopic beat, and then after about 3 minutes, he started getting into a sinus rhythm. And he sustained at a rate of about 90. And his pressure was pretty low. With the VA ECMO, we supplemented it with vaso, and we supplemented it with levo. This patient was subsequently taken directly to the cath lab. And in the cath lab, this patient was awake and fighting them. So it's crazy. Within 30 minutes of this patient, after post-ROSC, after being down for about 65 minutes, he was actually awake on the cath table and fighting and requiring sedation. So we felt this was a great victory for us. I talked with the heart failure attending and I said, listen, this is what I saw, and this is the rhythm he went from. What do you think could have caused this? And he said, this is 100% rejection. And you will see this in heart transplant rejections, where these patients will have basically a high drive and their heart literally is rejecting, and they will completely bottom out on you and they will go into asystole. And so this was acute rejection. This patient, 1 day later even, was awake, following commands, nodding yes, in the coronary intensive care unit, and was still in ECMO. His EF was about 5%.
Wow.
So the hopes is that he is rejecting, obviously, and they're giving him therapy for that, and their hopes is that maybe that they can actually get some EF back, and that he might be able to have a heart that's still salvageable.
So did they keep him on ECMO the next day while they...
He's been on ECMO. I haven't followed his case just yet. I'm going to get an update probably this week on how he's doing, but still a remarkable case. We gave this guy every chance that he has.
Yeah.
Definitely.
Yeah,
Well, it's
It's a great case.
Yeah.
yeah. I thought it was a great case. I learned a lot from it.
What else did heart failure do besides taking him to the cath lab?
They gave him 1 gram of Solumedrol. That was the only thing that they
For the
gave.
acute rejection, yeah.
Well, yeah.
Yeah.
That was the only thing they gave in
That's the only thing
addition.
they added.
Yep, and I said, what could I have done differently? And he said, you should have given this guy a gram of Solumedrol the moment he walked into your ED.
Right.
I said, okay.
Sure. I mean, it wouldn't have worked very fast.
Right.
But, okay.
Right. I said, okay, that sounds fair. I still do some antibiotics out too.
Right,
never
that's
have
fine.
sepsis. It could always be sepsis.
Right. So, but I thought it was a great case.
Yeah, it's a good case. I like that.
Yeah.
Good. All right, first article. Who's doing the first article?
We can do mine.
Okay, which one?
It's the D10, D50.
The famous Moore article.
So this article is from 2005, and the purpose of the article was to evaluate whether D10 given in 50 milliliter aliquots is more effective than D50 given in 10 milliliter aliquots in the treatment of out-of-hospital hypoglycemia. This was a randomized controlled trial in the UK. And what they did is they enrolled 51 unresponsive adult patients with a glucose of less than 4 millimoles per liter, which I don't know what that translates to.
81 milligrams per deciliter, right? Or no, I'm sorry, 72.
Okay.
Apparently you multiply it by 18. I had to look this up to go from millimoles per liter to milligrams per deciliter, which is what we're used to. You
Gotcha.
multiply it by 18.
Okay, so
So
it's less than 72. Okay, cool. So the way that they did it is they had, they previously had some randomized folders that they had in each of the ambulances, and they would any patient that they thought would be enrolled in the study, they would just pull out one of the envelopes and use whatever was in there, and then they would kind of go about their treatment as is. It wasn't possible to make it a fully blinded study because the paramedics were, once they opened up the envelope, they knew kind of which one was which, just based on how it was going to be given. And they evaluated, their primary endpoints were the time from treatment to return of GCS to 15, and then they also evaluated their post-treatment glucose levels and the post-treatment GCS as well. So what they ended up finding is that what they found was that there was no real difference in time from D10 to D50 to back to a GCS of 15, but they did find that using D10 ultimately resulted in lower total post-treatment glucose levels. And so one of the biggest issues of using D10 versus D50 to reverse hypoglycemia is that you end up then getting hyperglycemia and having to deal with that afterwards. So what they found is that the D10 delivered in 50 milliliter aliquots required smaller doses of dextrose and also resulted in much lower post-treatment glucose levels.
I thought it was interesting when they talked about the interventions and that it says that they were supposed to wait like a full minute between doses. And I'm wondering if they were really doing that between the 50 ml pushes, because that's a lot of fluid to push.
Right.
And so I feel like it just takes longer, so naturally the time it takes you to give the 50 ml aliquots is going to take longer, so you give less overall.
Right.
Right.
They didn't wait a minute, did they? I mean, in real life, what do you think?
I feel like probably not.
Yeah.
Well, how many patients needed a repeat dose of dextrose in the D10 group?
Probably like, I don't remember.
So in D10 it was, I think 4. So it was subjects with further hyperglycemia.
So that was not there.
It was the same as.
Right.
I don't know if I remember reading where that was.
So, I mean, this is obviously one of the studies everybody talks about in determining what to do. So, because we don't give D50 anymore, right? We don't give D25. We give D10 to everybody. AJ, what did you think?
I mean, I think it's kind of cool because of the study that we just did.
Right. So we just did dare I say, a better study. But, but listen, he did this in 2005, where we were all giving 3 amps of D50 to everybody in 2005. Who knows what we were doing?
Or even part of the coma cocktail.
And we had we have a really good study which we just submitted and for abstract, and then we're going to write an amazing paper that everybody in the country is going to pay attention to. We have some very significant results. But in the meantime, what do you think about this?
It's just so similar to our study, but of course we're retrospective chart review, not a prospective clinical trial, and I don't really have anything true to say about it besides like their effect is that you can't really see it due to the low sample size, and that's kind of why we have such a large sample size with our study. And like they're powered to discern these differences between the group. I think from what I'm seeing, especially with what we've seen in our own study, then again it's a different population because it's UK, is they're actually underestimating, in my opinion. I think they're underestimating the results of the difference in proportions of hypoglycemics. And that's probably most likely because of their low sample size.
So are you saying their study was underpowered?
Yes.
I mean, their N is very
60
small.
patients isn't,
Yeah.
you know, not that many.
So did they comment did they do a power calculation?
I would assume not because, I mean, I don't know. I would assume not just because of the low sample size because it's probably unnecessary. But let's see. They did a power calculation on GCS, but that's it. They didn't do a power calculation on detecting hypoglycemics post-treatment.
Because they knew they wouldn't
Hyperglycemia.
have enough patients for power calculation?
Yeah, most likely, yeah. Because it's very unnecessary unless you have well over 100 in each group.
All right, so Ariana, in 2000, would you have changed what you did in 2005 based upon this study? Because we all kind of ignored it.
I think,
I mean, if you were running a large EMS system, I mean, for that matter, all the emergency departments as well, because
Yeah.
they were all giving D50, would you have stopped giving D50 in 2005?
I don't think that this would have been enough for me to really change all of that, especially because there was discussion in the article about how administering D10 versus the D50 was a little more cumbersome and it took more time, and
Right.
time on scene was a little longer in the D10 people, and so I think it probably it wouldn't have been quite as easy to just jump on it and say absolutely.
Right. I mean, but at the risk of keeping you in the hospital longer and increasing the risk of nosocomial infections, and at the risk of saying, let's just wait for another study to come out, but here we are now, 13 years later, and most ERs still give D50.
Right.
Because everybody has been saying for the last 13 years, let's just wait for another study. Because this is what I always say, when you don't have enough data, you have to make good decisions. And maybe the good decision is to do nothing. But I mean, what would have been the downside if we changed the way we practice in 2005 based upon this?
I mean, I guess I don't think that this article really delves into very much the outcomes beyond the pre-hospital
Right.
area, and so I don't know that, I agree with you, I don't know after reading just this that it would have been enough, because there's really like 2 or 3 sentences at the very end that comment about how hyperglycemia, like if you avoid it, it's neuroprotective and it reduces mortality, and that's pretty much it. It doesn't prove that. All this proves is that there's really not a huge difference in the outcome other than that your glucose stays higher for longer with the D50. And
Right.
but they don't, like, if I was just looking at this paper, I don't think that it would be enough.
Okay, so that's a fair point.
I mean, does the start in D10 versus D50 really take up that much more time? I know
think the
for a
way
fact
they-
that there's so many, I have so many hand cramps from pushing
Oh,
D50.
my hands are tiny, so I have the same problem
I
trying
think
to push
it's-
a whole amp.
I think what she was saying is this article in particular, because they had to give it in 50 ml aliquots. So you had to, using a stopcock, draw up 50 mLs, turn the
Right.
stopcock, push the 50 mLs, wait a minute, turn the stopcock, pull up 50, wait,
Oh,
you
yeah,
know what I'm
that's
saying?
terrible.
Whereas here, we've just been hanging D10, and like what I've seen at least
Yeah.
with paramedic, they
It's
just
easy.
like
That's what
drip
I
it
do,
in
yeah.
at like a TKO or whatever.
It's much easier.
When the
And-
patient wakes up,
There's
either
no
can
calculations.
continue it or turn it off.
Right.
And let them eat
Not only that, but we're leaving the vast majority of those patients on scene. They're going to wake up in RMA, so what does it matter if it takes a little bit longer?
Right.
That's true.
That's true too.
That's a good point.
All right. I mean, did you guys all wonder too, didn't you ever do like a PZR shift one day and the next day you did an adult shift and you had hypoglycemic patients, and when you're in the PZR you give D25 and the next day when you go to the adult ER, if you're one day older you get D50.
Right.
And isn't that why? Why is why does anybody need D50 ever? Because we made it up one day but it doesn't really make sense. And then some people say, well, they just give half an amp, and I usually say, okay, but that's made up too, giving half an amp of D50. So, is there anything else we can take away from this?
What's your recommendation on patients retreating for hyperkalemia and you're giving them insulin with dextrose?
So that's a good question. So generally, my recommendation is 200. Like if your blood sugar is over 200, not to give the dextrose. If you're under 200, to give dextrose with it. remember when you give dextrose to somebody hyperkalemic, there's something called the osmotic effect. This is very important. And that means the first thing that happens is your potassium goes up, right? So when you give dextrose to somebody, the first thing that happens is your potassium increases, right? That's not really important in you and me, right? But if for somebody whose K is like 6.2, that 6.4 can cause them to go into cardiac arrest if they're an acute hyperkalemic who's not a dialysis patient, right?
Sure.
So you have an osmotic shift to somebody when you give them dextrose, and the potassium goes up automatically. So, I mean, that's generally how I do it. Under 200, I give them dextrose. Over 200, I don't, because I don't want to make them even sweeter and risk that hyperkalemia go into cardiac arrest. And that's what happens. So just be very cautious in those people whose potassiums are high to start with.
And what would you do? Would you do D50?
Right. Well, I think it's different if you're pushing insulin in somebody.
Sure.
Right? I mean, I think it's different. So for those people, might I push dextrose? Because I think that if you are hyperkalemic, I don't feel like I'm trying to push those people out the door anyway. Those people are just not going to go home.
Right.
So I feel differently about them, and their blood sugars are not my main focus at that point. Their hyperkalemic death is my main
Right.
focus. So to keep them a little bit higher, and I've seen too many people get hypoglycemic, and it always makes me feel a little uneasy that I'm pushing 10 of insulin. I mean, we know the data shows you don't need to bolus insulin in anybody, right? So when you're in DKA, it's been a perpetuated myth for years. The myth used to be that if you're an adult, you should bolus insulin, and if you're a kid, you don't bolus insulin. And then we learned that that was totally wrong too. That you don't need to bolus insulin in anybody who's DKA. This has been studied. We've looked at this. I mean, when did you guys get taught in residency?
Bolus, then drip.
Bolus and drip.
Kids don't get bolus.
Yeah, it's very
They're very specific.
independent.
Yeah.
Right.
It's-
You got
I know for
taught
bolus.
kids don't bolus and adults don't. And did you ever say, why is that? Right? And the answer is because somebody was making it up. But there were studies, and that was because there was a study in kids to say that you shouldn't do that in kids. Then there was a study in adults to show that you absolutely shouldn't do it in adults. So the answer is you shouldn't do it in anybody, right? And you have no risk of anything bad if you don't do it, right? So it's the insulin drip you need, not the insulin bolus, right? I mean, what do you guys do in real life now? Do you ever give insulin boluses anymore?
Not for DKA.
I don't, not anymore.
Yeah. Yeah, who cares? I mean, you don't have to rush to the finish line, right?
Right.
With DK, I mean, you have to if you can get them better in 12 hours, it's perfect, right? But you don't need to get them better like in 1 hour, right?
Agreed.
When I was a resident, you're not going to believe this. We actually put A-lines in all our DKAs. And if you admitted somebody to medicine service, because I was a medicine resident first, if you admit somebody, you had to get them better by morning report the next day. And if you presented somebody who was still in DKA with morning report, you were considered to be a failure as a medicine resident. But you put an A-line in everybody. Can you imagine every DKA would put A-lines in? And if you didn't,
Wow.
you were thought of as like something was wrong with you.
Right.
I did that in peds, and we would just take do BMPs off of that like every hour.
Mm-hmm. BMP.
Or-
Right, who
Blood
cares? I
gases.
mean, it's all like, you know, is your gap closing? Is your gap closing? Right.
Just treat them.
Right, right. And do DKAs only to go to the ICU? Isn't that a myth too? You know, there are hospitals where DKAs never go to the ICU.
You manage it on the floor, sub-Q.
Right? I mean, why? Right? I believe you can admit any patient to anywhere as long as you're the right person taking care of you.
Right.
Right? You can admit your DKA to the street, to the roadside, as long as somebody's rechecking your blood work and keeping on top of you. Why does it have to go to the ICU? Like, I mean, if you're a DKA and you're sick and you're septic and you're hypertensive, sure. But if you're a DKA, I mean, for that one, if you're a DKA, I used to believe that if you were a DKA, you had to go to the ICU, and it was a no-brainer. And then somebody said to me, well, why can't you keep them in the ER for a few more hours, see if the gap closes, because they're right on the borderline. Their pH is 7.25. And then I thought, yeah, why can't I do that? Why can't I see if I can get them better and maybe even repeat the gas and, you know, or the VBG? And the answer is because it's not an ER way of doing things.
Right.
But, you know, but now, unfortunately, you know, those people admitted to the ICU stay in the ER, right? And
Right.
you can probably close their gap quicker than you can get them to the ICU.
That's true.
You know? So what's wrong with managing some DKAs? I think nothing.
10 other people waiting for that bed.
Yeah.
Yep.
All right, next article.
So I'll go ahead. So I think one of the biggest articles that came out this week that's making some waves is the Pamper trial. We're good? So we actually, okay, you guys can hear me?
Yeah.
Give me a like. All right. So we actually had 2 articles today kind of related to the PAMPER trial. So what are we talking about here? So this is the pre-hospital air medical plasma trial. There's a little bit of an introduction paper if you guys read the paper on pre-hospital damage control resuscitation. This concept is basically talking about about in general using blood products in the field, what blood products we use, why we use them, and why this matters. So they just kind of introduce here that about 50,000 Americans die every year from hemorrhage, which is a lot. We have a lot of trauma centers, and I'm surprised that this happens. And most of these deaths not only occur from hemorrhage, but significantly shortly after hemorrhage, so within 2 hours of these injuries. So the question here is, the concept of using plasma isn't really a new concept. It's been used all the way back in World War II. Back then they called it field plasma, and that was the only thing that was ever given. But they found out that it wasn't enough. And today the concept is, can we use damage control resuscitation, which is basically all different types of blood products, plasma, platelets, red blood cells, in equal proportions. In most places we call this a massive transfusion protocol, while decreasing the amount of crystalloid we use, so normal saline, lactated ringers. And that was basically the first article, just a quick introduction about that. So moving on to the actual PAMPER trial itself, this was done out of Pittsburgh, and the study was performed to determine if it was safe to give thawed plasma pre-hospitally, and to check the efficacy of that as well. So a multi-center cluster randomized phase 3 superiority trial was conducted, and the primary outcome of the study was to determine mortality within 30 days. They recruited about 500 patients, 501 to be exact, and 230 of these patients received plasma, and 271 received standard care, which in this case was generally limited to crystalloid resuscitation. It was a little vague as to exactly how much crystalloid this was, and some protocols were different in different places, and in some parts of the trial blood was given as well. So basically the results were very significant for this trial. So in the group which received plasma, mortality at 30 days was 23%, and in the standard care group it was actually 33%, 10% more. When calculated out, the number needed to treat to give plasma was actually 10, which is a very significant number. We don't see a whole lot of interventions in emergency medicine where the number needed to treat is that low. So that's probably why it made a lot of waves this week. Then the conclusion of this study was that it is safe indeed to give thawed plasma pre-hospitally for hemorrhage. And in this setting, it was done in the air. So in terms of just a little bit more about how the study was conducted, I thought it was pretty interesting, the randomization scheme. So basically they went by different air bases. So some air bases received plasma and at certain times, and some didn't. And then technically a second randomization occurred because whoever was available to respond to treat this patient showed up. So you're kind of randomizing in that respect as well. And
Is that what they refer to as the cluster randomization?
so that's basically what they meant. Yeah, so the cluster was that at 1 block intervals, so if you had airbase A, they would get plasma, airbase B may not get plasma, and then at any given time, A or B can respond, and which is always random what helicopter is going to show up in Pittsburgh or any other state, based on distance and availability of where the call occurs. So I thought this was a pretty fantastic article. AJ, do you mind just talking a little bit more? They performed this 2-sided pooled z-test for the 30-day mortality study.
A 2-sided pooled z-test approximate all of your samples into a normal distribution, and basically it just undergoes the assumption of normality, and that, let's see, trying to figure out the table that they're exactly using this on. Let's see. I'm not sure exactly which table they're using this on. I don't see it. Because a z-score in and of itself is just difference testing between two associations. And when they mean pooled, they're just saying that the variances between the groups are the same, between standard care and plasma. And it's a pretty big assumption in statistics because you want your variances to be equal between your groups because it gives you a more accurate approximation of the effect you're seeing if the variances are equal. It's kind of a little bit of a big deal. And let's see. I would like to talk about the Kaplan-Meier survival curve for a second on, let's see, page 322. Every one of those notches you see is actually a step. I found this curve to be a little different than most Kaplan-Meier step curves because usually they step down for every time you do them, but the curve is so pulled out that you can't really see it. And so each one of those black notches you're seeing is an occurrence, and that's why they're usually all at the beginning, decreasing the rate, and it's flattening out. So those little dots you're seeing, or little notches, are kind of where all of the occurrences are occurring, and that's why they clump up and get a little darker, but you can kind of barely see it on the graph because it's so zoomed out due to the denominator, the hours since randomization, being so large. So I probably would have divided that by a larger equal number throughout so you could zoom in a little bit because it's kind of hard to read.
So what do all those steps mean in terms of significance for us and these findings for 30-day mortality?
They basically mean that they all occur at the start, which is what you kind of assume. And basically it just stops and drops off. That's why it goes to a flat line. So the rate of change is very minimal, and it's all at the beginning. That's kind of how you're supposed to read a Kaplan-Meier curve. Because it's usually called a stepwise Kaplan-Meier curve. It usually goes down like a zigzag plot, but this one's so zoomed out you can't really see that.
Yeah, if they cut it off at like maybe 200 hours, we would see a lot more.
I would have definitely zoomed in if this was my own graph.
So if I'm understanding this correctly, this means that the earlier they were randomized, or in this case, the earlier they received the plasma, the more of an effect it had.
Yes. Yeah.
Wow. What do you guys think of that?
And can we say by how much, at what time period?
The Kaplan-Meier curve doesn't say anything about that. It literally it's just a descriptive statistic tool.
They did find in the study that they had a significantly lower mortality both at 24 hours and at 30 days.
Yeah, because that's their clustering. They're just like grouping everything into like an interval and calling it cluster or a block. Same thing, stratification.
So what else can you tell us about the way the stats were done? Anything else?
Let's see. The pooled estimate we have overall, if I'm not mistaken, this is fixed effect modeling, right? Where's random effects? One second. Oh, it doesn't state. Okay, never mind. Let's see, the pooled estimate is protective for plasma because it is below 1 on page 322, table B, for plasma for all subgroups. Let's see.
One thing I found really interesting about this study too was just in determining subgroups. The study that when they chose to give plasma, it wasn't in healthy participants or healthy trauma patients or anything like that. They had to be hypotensive and tachycardic in order to get this. So I think, the fact that they found significant results with sick patients who we would want to treat like this is pretty significant.
Yeah, because you can interpret the pooled odds ratio at the end of 0.61 as a 39% decreased likelihood of each one of those events occurring overall.
So say that one more time.
Let's see it. 39% decreased likelihood of each one of those events occurring overall.
Okay.
So it's pretty good. It's definitely in favor of plasma.
So our problem with giving plasma pre-hospitally is the refrigeration. right? Or at least how it's frozen.
Right, so they actually addressed that in that little intro study. So there's a difference between fresh frozen plasma and never frozen plasma liquid. So you can give it in either form. And the fresh frozen plasma you can give once it's thawed, because it's frozen and then thawed, you have only 5 days to give it, which is
Right.
what they did in this study.
So that's the problem with, so trauma centers will keep FFP thawed, non-trauma centers will oftentimes not do that.
Right,
And then you have to go, and then it's only good for 5 days, like you said, and that's a standard number.
right. However, I guess they, in the other article, they did mention that there's an alternative with never frozen liquid plasma that's just kept in a refrigerated liquid form the entire time, and that's actually 26 days. So,
So 26 days. So the next thing is FGP, freeze-dried plasma, right?
It says that's not approved by the
not yet.
Right,
Yeah.
so they're getting pretty close. I was speaking to the rep a couple of days ago, and he would say they're getting really close. And of course, I asked him if we could get it once. But it's a very good pre-hospital drug, a drug, that you can give pretty easily with temperature not being a problem.
Right.
So that would be good. It would be really good for us. Because, I don't know how we carry FFP.
How we would carry?
Yeah.
I guess we would have to buy fridges or freezers.
Right, but the problem is we'd have to measure the temperature in that around the clock, right? Because it's just like the hospital, when you have refrigerators, it has to stay as,
Certain temperature all the
if it's
time.
blood has to stay between 2 and 8 degrees Celsius, and you have to have an alarm system if it goes out of range to be able to check on a regular basis.
Right. Some box truck ambulances, believe it or not, have built-in refrigerators with temperature.
Right, that's what I used to do with the physician vehicle, but the regulations were really, really tough. And the vehicles had to be plugged into, obviously, shorelines in
Exactly.
your house, et cetera, et cetera. It made it very challenging. And with freeze-dried plasma coming soon, I hope, I didn't follow up on getting FFP. I guess that's the question, when's freeze-dried plasma actually coming out?
I mean, they have it, it's just not approved, so they just need to get a prospective study going.
But there are pre-hospital studies on freeze-dried plasma under research protocols.
Yeah.
So, is this something that if we are calling the helicopter to the scene, we can tell them to bring it with them? Is that something that's possible?
Sure.
It depends on the system. So some of them have it readily available. So when they're activated for trauma or something, they'll actually automatically just grab a pack and bring it. Just like when we're activated, if we need blood on the scene, like we call the.
Most helicopter systems in the United States don't have blood, right? Don't give blood. Some do, and I don't know which helicopter systems in the civilian world carry plasma.
Right.
But when we've looked at this in Journal Club before, there are only a couple in the United States that carry blood. Like, we can carry blood, but most times operationally, I'm being told that the incidence that we would give it is so few and far between. That's the problem.
That it doesn't offset the cost of.
Yeah, I'd be totally supportive of it if somebody wanted to do it, but I'm not going to do it if people don't want to do it.
So a lot of it, there's a couple of things. One is semantics itself. So one, remember that in a helicopter, space is very, very precious, and weight is very, very precious. And so being able to create refrigerating systems within a helicopter, that's added weight to the helicopter. And then having a box that's going to have to fit somewhere is going to be also another added space occupying issue. So these are things that are very, very challenging. So every time that you do that, there's a discussion about just the actual semantics of it. The other side of it is that, the logistics behind the blood itself. Now, many helicopter systems are stationed somewhere aside from a hospital, so they're not actually from their actual base hospital, and so that becomes challenging. So like for our system, we're actually at an airport, so it would be hard to actually have access to blood. Secondly, we go to multiple trauma centers, and so we're not actually feeding it to one trauma system, that where we could retrieve blood from that system as well. So that's the second challenge. Houston does blood, obviously. And one of the things that's appetizing about Houston is that, one, they have, I think, 6 HEMS, and they all feed into Memorial Hermann, the trauma center. And so they basically are all coming to one trauma system from all over the greater Houston area, but they can replenish their supplies at the trauma center they go to. And so for them, it's easy, because even if the helicopters are so heavily utilized because of the population density and the traffic, that as their blood's expiring, they can circulate it back into the trauma center, which will be immediately utilized, or back into the hospital, which will be immediately utilized, and then they can divvy up more that expire later on. So the issuing aspect of it is also key, but having that ability not to waste blood is far more important. And if you have a system that actually feeds into the hospital, and you feed into one hospital system, that actually makes things a little bit more streamlined.
Right. We didn't actually give blood at the scene last year for whatever reason, but the year before we gave it a couple of times.
Yes.
But it has to be somebody who's entrapped, going to be at the scene for a long time, who with clear evidence that they need blood, right? So hypovolemia, and if we have that, we give it, and we carry wide tubing and can give blood. I mean, there's no reason why we couldn't add FFP. There's no reason. I guess the answer is we need to check on the date for freeze-dried plasma, when it will come out.
Sure.
All right, do we want to do one more quick? Was there anything else with this study? So we like, what do we call this, the PAMPER trial?
Pamper. Yep.
The PAMPER. Because we're pampering patients who are...
So
All
when
right.
if I get a call on the medic phone, and it sounds like it's either bad trauma and patient's hypotensive with all these vital signs, should I be telling them to get 2 units ready, or is that
Telling them in the ER?
no? Like if I'm in the ER and I'm getting a call on the medic phone, that they say that they have a hypotensive patient who's tachycardic to the 130s and systolic blood pressure of 70, I'm telling the medic to get blood to possibly transfuse them. Is that something that we can do?
Well, there's nobody, I think, in the United States that could do that. So maybe sometime in the next many years.
Okay.
But
You know what you can give.
right, what can you give?
Chris?
TXA.
And why don't you want to give lots of fluid?
Because that hasn't been shown to be any benefit.
Because nobody bleeds normal saline, right? So, and if the systolic's at least 90 or 80 in some studies, we're okay with that. Right?
So that was another point in this article. So that was their protocol that they did already, their standard of care. We have a different standard of care here.
Right.
So I'm wondering,
Right,
compared
but this
to-
literature started with the military about not throwing fluids, at people, and this is true for most of the literature now, for everything from GI bleeding to keeping hemoglobins lower, like 7s and low numbers, so it's much different, right? Yeah, it's interesting. I don't know. I mean, we're not just rushing to give fluids, but everybody wants to still. I've noticed
They
that.
do.
I've always, a trauma patient who's pretty stable, and they want to give like a 500 ml bolus of normal saline. I don't understand why, right?
MD20?
Yeah, that's right. I was just gonna come and see if you need
Yeah,
it.
we've been calling it. We've got it heavy and trapped down the
Okay.
street.
Right. We'll keep going.
I thought I didn't bring it up.
Okay.
We'll try one more article.
I think mine might be pretty quick. The drugs in cardiac arrest.
Sure.
So, so the article that I did, drug therapy and cardiac arrest, a review of the literature. So basically, these authors, which it was a study that was done in the UK, I believe.
Your local fire.
They essentially reviewed the literature that was already published through PubMed databases and Cochrane Review, and they did all of these searches to determine which drugs are beneficial in cardiac arrest, which drugs improve survival, increase ROSC, and increase or improve 30-day mortality. And basically they found that no drug really does any of that. No drug is really great or increases
Or
survival.
as I call them, the poisons, right?
Yeah.
Poisons don't work.
Yeah, they don't work. So, in kind of relating it back to what we do now, in our ACLS protocol, we give epinephrine and we give amiodarone, but these these authors reviewed the literature. I think they had a total of 88 prospective interventional and retrospective observational studies, and they went through each of these studies and they determined whether or not the drugs that they give, both epinephrine, amiodarone, they look at things like vasopressin, corticosteroids. They look at TPA, methoxamine, isoproterenol, all of these things. They looked at whether or not giving any of these drugs increased ROSC or increased 30-day survival or 30-day mortality. And they basically found that there isn't any benefit. One of the more interesting, so kind of a couple of the hot topics that I just wanted to touch on. They were looking at, with regards to epinephrine, they went back through the review and they found 33 studies that were written regarding epinephrine administration. There were 15 were interventional epinephrine studies and 18 were observational studies. And of the 15 interventional studies, 13 of those interventional studies compared giving high-dose epinephrine to standard-dose epinephrine. And only one of those studies, so one of the 13 studies, found an increased survival to hospital discharge. And that was a pediatric population.
Yeah, I mean, a lot of that's Joe Ornato's literature, which he showed in the 80s.
Right.
Which kind of said high-dose epinephrine for standard dose makes no difference. But then we know from the Paramedic 2 trial now that it really makes no difference.
Right. How'd you say his name? Janad? Jerry?
Joe Ornato?
Oh, I thought you were referring to this study in the largest study of 3,000 patients that they reviewed here. They reviewed, the largest study that they had was a study of about 3,000 patients. And even though that patient population had a higher incidence of ROSC, their survival to hospital discharge was not significant compared to the standard epi group. So that was kind of one of the things that I wanted to talk about. And then the other thing, the more interesting thing was they actually found that there was a prospective study that when they went back and they reviewed, the study was giving vasopressin, steroids, as well as epinephrine in this intervention group, and they found that that was really the only study that had a good neurologic outcome. And the study design sounded like it was kind of complicated. They gave vasopressin in addition to solumedrol, and then corticosteroids during an epinephrine during the first dose of all of those medications when a patient came in with cardiac arrest, and then they continued giving corticosteroids, and they found that those patients had pretty good neurologic outcome. But again, that was something that was reviewed, and it sounded like the way that kind of went about was kind of complicated or complex.
Yeah, I mean, for amiodarone, there's 2 trials, the ARREST trial and the ALIVE trial for the most part. Then there's a third one which just got added, which showed basically no benefit. And there's only one major study on. There's one big study on children that we reviewed 3 years ago, maybe 2 years ago, which actually shows lidocaine is better than amiodarone in kids. So for children, we do know if you're under 18 and you have VF or pulsus VT, which is rare in non-cardiac kids but does happen, lidocaine beats amiodarone. So we know that. And children give lidocaine, not amiodarone. For adults, it makes no difference whatsoever. And we're going to review a lot of these articles throughout the year anyway.
This I just found it in the paper. So the authors reviewed in 2 placebo-controlled studies, a group from Greece randomized patients to repeated doses of epinephrine 1 milligram, or a combination of vasopressin and epinephrine every 3 to 5 minutes. Concurrent with the first injection, 1 dose of solumedrol 40 milligrams methylprednisolone was administered to the intervention group. If hemodynamically instability developed after the resuscitation, hydrocortisone 300 milligrams daily with gradual tapering was administered to the intervention group. The first study enrolled about 99 patients, and there was a significant benefit in the treatment group for the primary endpoints of ROSC and survival to hospital discharge, 81% versus 52%, and survival to hospital discharge was 19% to 4%.
Yeah, we reviewed that trial. We all read it and go, this can't be right.
Why?
Because how could steroids make somebody better who's sick in cardiac arrest?
I mean, right, it's because it's I don't know. I was gonna say it's vasoactive, but I guess epinephrine is too, and as
Yeah.
well as,
It's just bizarre.
yeah.
Right, vasopressin doesn't work in cardiac arrest. Ian Steele proved that right after vasopressin was approved by AHA. Ian Steele did a study immediately after to show it, and did a great study to show there's no benefit of vasopressin in cardiac arrest. Despite that, we kept it in ACLS for several years after that. But for steroids up in cardiac arrest, when the poisons, the antiarrhythmics don't work, the epinephrine doesn't work, nothing works. For steroids to work, it's just kind of strange.
Yeah.
That's something I feel more comfortable saying that you need to replicate this before I start giving you steroids in cardiac arrest.
Yes.
Any other thoughts about that? No? All right, so we're gonna stop early today because we have a lot going on. So did you say we're actually here next week?
Yeah, we're going to be down here next week because we're going to have our helicopter orientation.
So we're actually back at Monarch Boardroom next week. Thanks everybody for joining us. Remember to join our weekly email and log on to our website. We'll post this in the next couple of days. And the articles that we didn't get to, we'll push to next week, and we'll add a few more every week. We'll keep on the same pattern of adding new, fresh ones that come out in literature and a few old ones that are classic stuff. All right, have a great week. We'll see everybody later.